Good evening, everyone. This is Meldita, and I'm back. So this is part 2 of non-STEMI versus STEMI, small heart attack versus big heart attack. What will an RN do? And this is English version. We will be discussing 2 patients here, STEMI and non-STEMI, that need to go to the cath lab. Coronary angiogram and percutaneous coronary intervention, which utilizes stent insertion or balloon inflation called POBA, or plain old balloon angioplasty. These procedures are done in the cath lab. Coronary angiogram is actually a heart catheterization. So the cardiac interventionalist is the one doing this procedure with the cath lab staff. Okay, so he can decide whether to get into the radial artery, right here. That's the radial artery here. Or femoral artery. So the things needed for the procedure, they use a local anesthetic, big needles, small and long guide wires, coronary catheters, balloon catheters, mild sedation for the patient will be awake. So if he decides to get into the radial artery, the coronary catheter will pass from the radial artery to the brachial artery, to the subclavian artery, going to the brachiocephalic artery, and passing down to the ascending aorta to the base. If the interventionalist decides to get into the femoral artery, so the catheter will start here, femoral artery, passing the iliac artery, to the abdominal aorta, thoracic aorta, descending aorta, to the ascending aorta to the base. So let's move on to my next drawing. So if the doctor decides to do first the left coronary artery, he will use a special catheter, left coronary artery catheter, to the left, right here. So once the coronary catheter passes the opening here, they will inject the dye to see for blockages. And if he thinks there are blockages in here, he will make a decision to stent or just maybe POBA. But first, he will thread in the balloon catheter. They found that there's a blockage there, let's say left anterior descending artery. So he will put in the balloon catheter, okay, and that catheter will be between this plaque, compress them as he inflates and inflate more, and then after that he will deploy or put this stent inside the balloon catheter right here, inflate it, the balloon and the stent will be inflated, and then leave the stent in place. Let us just say this is left anterior descending artery that has a blockage and had a stent in place. After the left coronary artery is investigated, the doctor will use another special kind of catheter for the right. These 2 catheters are different. There's one for the left and there's one for the right. So the right coronary catheter is in, passes the right coronary cusp, inject the dye, investigate for blockages, and then if he thinks there is, whatever, he makes the decision whether to put a stent or not. Okay? When the procedure is finished, if it is radial approach, he will use a radial band. If it is femoral approach, he will use perclose or special kind of suture, angioseal, or a clamp will be removed by the cath lab RNs or the CCU RNs. Okay? So that's about that. So we have 2 patients coming in for the cath lab. So let's discuss first the inferior STEMI. Okay? The inferior STEMI, we have an elevation in the leads 2, 3, 2, 3, and F. This is the inferior STEMI located at the diaphragmatic area of the heart, so mainly at the base. Okay, so we have an ST elevation okay, that needs to be done right away into the cath lab. So before that, what's going to happen if we don't do anything about it? So this is the evolution of the acute STEMI. When you see this kind of ECG here, this is normal. That's normal. Next, this is acute. If they appear like this is a very good chance right away back to its normal circulation. We save the heart muscle right away. Okay, so in here it is normal. You don't see any ST elevation. Here we have ST elevation that is acute. In here, we still have an ST elevation. We started to develop Q wave. Okay, right here, that is more than, let's say, 0.3, more than 0.03. And then, that is for hours. Okay, and if that is, let's say, day 1, 2, or 1 to 2 days after the attack, the Q wave gets deeper. The ST elevation is still there. Okay, and you got a T wave inversion. And if the damage progresses, days later, the Q wave is still there. The ST segment normalizes, isoelectric, but the T wave is still inverted. And weeks later, the Q wave is still there. The ST segment normalizes or isoelectric. The T wave now is upright. Okay, what is the aim of the staff to this, with regards to treating our people? If we can break the progression of this damage, so much the better. So the earlier they come to the cath lab, the better. If they come with this, these are good prognosis. These are good. If they come with this is late. So if you allow your acute ischemia to last longer, there will be more cell death, and that affects the heart pump. Okay, so in the case of this example here, this inferior STEMI here, there is ST elevation fresh from 2, 3, and F. Okay, so that is before stent insertion. So the angiogram showed that this patient has a blockage in the right coronary artery, the RCA. Okay, and this RCA actually supports the inferior part of the heart and 10% also the CERT. So in this case, if you see it's a long one, it looks like the patient has had 3 stents put in. Okay, so look what had happened after the stent insertion. So this is after. You see that this ST elevation now looks isoelectric. Look, this was great. So 2, 3, F. Good job by the team. Okay, that was good. Done early. Perfect. Very good. Perfect. This is really good. We like this. Okay. So in the case of a non-STEMI, a patient came in to emerge or maybe call 911 for same symptoms as the inferior. So the ECG showed depression. So we have a subendocardial infarct or MI. And the ST depression are quite deep. B2, B3, B4, and B5. And because of that constant pain, the decision is, okay, it's not ST elevation, but the pain continues. Let's bring the patient to the cath lab. So this is the decision of our cardiac interventionalists, okay? They went in, so they saw this blockage in here.